welcome to Season 2 of the Strength and Chiro podcast. This is Episode 7. Can I get an episode check from you, Stephen? Is it Episode 7?
I believe so.
You have no clue, let's be honest. Okay, Stephen, before we proceed, where's the dog?
He just ran away. He was in here just a minute ago.
Oh man, you got to get the producers on that. That's just, it's not a good look. This whole show is just falling apart. I have many people to introduce. We'll start with, I call him Redmon. His name's Redmon, Tony Stark of Chiropractic, the co-host of this podcast. Welcome to your own podcast, Stephen Redmon.
Thank you.
All right, there you go. Get that out of the way. Where do I start? Oh my good Lord. We have some of the best rehabilitation gurus, experts in the world, around the globe. And we're talking all around the world, 7 a.m., 9 a.m., 10 p.m., 4 p.m., 5 p.m. We are tuning in from multiple locations, and I'm very excited. So there's going to be 9 of us. Dr. Dre is on his way, but I'll just go through real quick. So obviously, Dr. Locke is there up in the right corner. Hot off the US tour, just from the Elite FTS, talking with Tate. How are you doing, sir?
Freaking awesome, man. All charged up, all fired up, rested, tanned and ready, and landed back in fucking winter in Melbourne. So the tan's going to do me a lot of good, man. It's been a tour of gems over there. It's been phenomenal. So I'm looking forward to giving you a few of the insights into what's really happening in the strength world.
Well, we're looking forward to that, and hopefully this will be a positive amongst the dip. It is coming back to Melbourne in the cold winter after being over in America. And then next over, we have the man, the myth, the legend. He has a biblical-sized beard. Mofo, Aaron Caseley. How are you doing, sir?
I'm doing good, bro. How are you?
I'm well, thank you. And what time is it where you are in the UK?
It is 10 p. It is actually 12 minutes past 10 in the evening.
So the lads from the UK are doing it hard tonight, that's for sure. So we really do appreciate you guys tuning in. And then across from that, we have Giles. How are you doing? You absolute legend.
I'm good, buddy. Yeah, thank you for having me. Also, hi to everyone. Nice to meet you finally.
Really looking forward to what Giles has to say. I mean, if anyone has seen any of our previous content with Giles, he is definitely no bull to the point. Extremely
lower your expectations.
Extremely intelligent. He is he's an absolute legend in the industry, but he likes to call it, he's a legend in his own lunchbox. There you go. Moving across from there, we have Dr. Marv, and coming in from Texas at 5 p.m. How are you doing, sir?
Great. I got off easy today with the time, so I'm chilling. People
Awesome.
are getting up way too early or staying up way too late to do this, so I'm lucky.
And what's your day been like? Have you had a good day?
Yeah. Did all my online coaching client stuff, finished notes from Friday, working on a online CCSP course to get those letters so I could branch into that, and then doing this with y'all now. So super excited. And
have you had a very busy week?
Yeah. Worked all 7 days, probably 8 to 12 hours each day, which is normal, but I love it.
Yeah, I asked because obviously the other day we were discussing, we were talking about all of your hours over the last kind of year, your annual hours, and it was insane. So an incredibly hard worker, not only the smartest in his class, graduating the top of his class, but incredible experience through the industry. I mean, you've been training people and doing biomechanics since I was probably in high school. So you're absolute legend. And I'm looking forward to hearing your insight. Definitely, you've got a very cool topic, and you're actually going to be starting us off when we get into it. So I'm looking forward to that. Next down there, we've got Luke Gichard, the legend from Auckland. He's coming in same time zone as me. It's around 9 a.m. for both of us. How you doing, lad?
Yeah, very good. These are probably the best hours we've got, out of everyone on the potty today. But just appreciating the 3 seasons we get a day here in Auckland, and it's only 9:14 a.m. So we're taking off all sun, rain, hail, shine.
Moving on, Matthew Lewis. Matthew Lewis is a PAC. We did a whole podcast with Matthew where we went into some of the very interesting parts of his world where you have to manage the chronic pain by day, working when you're in the chronic clinic, and then working with people with this more conservative McGill type stuff. So looking forward to hearing you talk around prescription pain meds and musculoskeletal health and all that kind of stuff, which is really cool as well.
Good to be here for sure.
We have a Dr. Dre who will be dropping in. He's working today, so he'll just drop in when he drops in, and then he'll hit it from there. Once again, thank you all for being here. I really appreciate it. It's been a massive effort to get 9 brilliant minds, I would say in the same room, but on the same screen at the same time. So thank you once again.
It is awesome to be here, man.
We are going to head into a large session of legit or bullshit. Dr. Marv, dry needling, legit or bullshit?
Legit. Dr. Locke, SFMA or FMS?
Awesome. Legit. Mofo, non-specific low back pain is a useful term in clinical practice.
Bullshit. Stephen, facet joint subluxation.
That's bullshit. I got one for Luke. Standardized testing versus practical testing.
Bullshit. Giles, nervoscope, legit or bullshit?
Bullshit. Matt, pineapple on pizza.
Legit.
All day long.
Dr. Locke, deadlifts for back pain rehabilitation.
Legit as hell, man.
Mofo, resting tendon injuries as a key strategy for recovery.
Bullshit. Giles, the body is a
Oh,
unit.
fuck. Bullshit. For old school osteopathic principles. Luke, do you need the click for the technique to be effective?
Bullshit. Stephen, spondies should stop you from doing daily activities.
1000% bullshit.
Massive Matt, if technique fails under a load, just increase the load.
Bullshit. Mofo, impingement syndrome as a diagnosis for shoulder pain.
Bullshit.
Matt, ultrasound for musculoskeletal complaints. Treatment, not diagnostic.
Bullshit. Luke, subluxation theory.
Bullshit. Locke, scoliosis is from poor posture.
Total bullshit. Brogan, pain science before learning biomechanics and complete assessment.
Absolute bullshit. Back at you, Locke. Knees caving in on a squat.
That ain't even bullshit. That's horseshit.
So, Dre, legit or bullshit, you must do spinal manipulation therapy on a hot disc.
Absolute bullshit. And I can tell you in the last 30 minutes, I did not do that on a hot low disc.
All right, cool. We'll wrap that up there. What we're going to do is that I've got a list here of people, so I'll let you know who's going when. The people that are listening or watching, the name of this podcast is the Ultimate Myth Busting Podcast. And I have found some experts in the field. We've got some young talent. We've got some medium age talent, not median talent. Everyone's high talent. we got some young blood. We got some people that have been around for a while. We got some people that have been around for a while. And everyone's super talented and very, very skilled and understand what they're talking about in the field that they're touching on today. And I'm excited to hear some myths busted. So pretty much that is what we're going to hear. We're going to hear from myself and 8 people. Everyone is busting a myth. That's the point of what we're doing. That's what we're talking about. And everyone has pretty much chosen a myth they're willing to kind of die on. Maybe, I don't know. At the end of the day, disclaimer, the point of this podcast is to be a little provocative for the fun of it and to have some fun busting some myths for the fun of it. So just thought I'd drop that out. So everyone's going to have 5 minutes. It's a loose rule. Try to keep to it. I'll set a timer, so you might hear the 5-minute timer go off, and then we'll hopefully have some questions if we want to, and then we'll move on to the next person. Everyone sweet? Everyone feeling good?
Right, buddy.
Yeah, pumped.
Awesome. So to start us off is going to be Dr. Marv, myth busting the myth that lifting weights is dangerous. I am debunking the myth that your CNS is always fried, for people that say that. Matt Lewis is kind of going to be talking around prescription medication for MSK treatment, and Luke is going to be doing unethical x-rays, debunking x-rays for postural reasons. Stephen is going to be debunking the idea that manual therapy is painful. Giles is going to be debunking spinal manipulation. Dre is going to be touching on orthopedic tests. Mo is going to talk about integrate versus isolate, or integrate, not isolate. And then Locke is going to come in at the end, and he is going to debunk this ridiculous belief, perpetuated belief throughout social media right now that technique doesn't matter.
Not a good idea.
Dr. Marv, when you are ready, take the floor.
Okay, so today I'm going to talk about how a lot of people, when I talk about what they could do for longevity, health, the whole 9 yards, is they worry that resistance training or lifting weights isn't that dangerous. Well, if you look at the research and how the research works when it comes to injury rates, is they pretty much do algorithms to get how many injuries occur per 1,000 hours of this activity. That way you could compare. Well, if you look at different styles of weight training, the numbers are shockingly low compared to what most people do when it's time to get fit and healthy, lose weight, or just become more active. Bodybuilding style training is only 0.24 to 1 injury per 1,000 hours. CrossFit is only 3 to 4 injuries per 1,000 hours. Olympic weightlifting is lumped in with that. Not to bash on CrossFit, but especially for beginners and that stuff, you are doing highly technical movements to failure or fatigue in a group setting with people screaming at you to keep pushing. You would expect that to have a fairly high injury rate, especially with 100%. How much that blew up. Coaching isn't always up to snuff, so you would expect that to be way higher than, say, running. Strongman, where you're purposely trying to blow people's minds doing stuff we're not designed to do. Only 4.5 to 6 injuries per 1,000 hours. The highest that I saw was Scottish Highland Games coming in at 7.5. If you compare that to running, for novice runners, some studies have that as high as 33 injuries per 1,000 hours, which blows all of the resistance training stats out of the water. To be fair, like high-end track athletes or long-distance runners who do it, like full-time, so to speak, that could go as low as 2.5. But for the average person who goes, I want to get fit and healthy, running statistically is night and like way above lifting weights. Now, why would we choose lifting weights? Just to do a super quick bullet list. Mental, all exercise is great for mild to moderate anxiety, depression. Cognitive health, especially for people with cognitive decline or even diagnosed dementia. Resistance training blows cardio out of the water. Ideally, you're doing both, but for cognitive acuity and dementia and all that, resistance training is the way to go. You're going to have improved insulin sensitivity, better lipid panels, blah, blah, blah. You're going to have a higher resting metabolic rate, which is nice when we live in a food-obsessed culture. So you're building up your budget for daily calories, improved blood pressure. A big one I don't think it's enough respect is bone health and preventing the loss of bone, especially in women, but like elderly folks, man. You could take calcium and vitamin D tablets like Tic Tacs, and if you're not providing load bearing, it ain't going to do much. You fall and break your hip, it's a 1 in 3 chance you're not surviving full out. So the bone loading benefits of resistance training cannot be like underestimated. Obviously, you're going to prevent sarcopenia, muscle loss, right? That pretty much prevents the aging process. In terms of any biohacker worth his weight in salt will admit that resistance training is probably the single best thing you could do for anti-aging. Quality of life's going to improve, whether that's reduced pain, improved function. We see reductions in cardiovascular mortality independent of cardio, as long as you're resistance training 1 to 3 times a week. I focus on that because I'm a former triathlete. The day I quit triathlons, I quit running. So if I'm running now, you better take off. There's a bear coming. So I like the whole cardiovascular stuff. And then I think we'll all admit, like, strength fixes a lot of shit. Typically, especially from baseline levels, if somebody is extremely deconditioned or weak, you get them stronger, a lot of stuff will improve. I loved going to retirement homes, working with older folks, because you get them to reach overhead or simply be strong enough to get off the floor when they fall down. So now the facility is no longer having to call an ambulance that's costing 10 grand a pop. Like, that could be life changing. So strength fixes a lot of stuff. The other big pushback I get to resistance training, which I find very entertaining, it typically comes from females more than males, is that whole, but I don't want to get big and bulky. To that, I say, do you know how many millions of people are purposely doing everything they can to get big and bulky, and you think it's just going to happen by accident? Like, I would admit, I'm pretty sure all of us on this podcast at one point tried to get bigger than what they were, and we're the best at what we do in the world, and we couldn't even do it. So it cracks me up when they immediately go to that, or I need to do super, 5-pound dumbbell curls with a pinky twist. No. So you would know before you ever touch the weight if you have the genetics for just being the best of the best. Like, the best example is, Mr. Olympia, Phil Heath. You look at that dude's arms when he was playing basketball and not weightlifting, his arms are better than 90% of all bodybuilders ever. And he wasn't even really resistance trained. Like, you would know. So it's not dangerous. It's actually significantly safer than what most people do, according to the research. It does a hell of a lot of good stuff. Now, I'm an educated meathead. I am very biased towards resistance training, but I think we get people, you don't have to train like a bodybuilder, just 1, 2, maybe 3 days a week, right? 2 minimum is my baseline. 3 would be great, but 2's better than 1 and 1's better than none. I think it's life-changing. It does a lot of stuff that other forms of exercise doesn't do. It makes you more resilient, and it gets people out of that I'm broken, I'm fragile mindset, because they're building confidence. They're seeing the improvements week to week. You might, most likely at some point, we'll see some sort of body change. Like, that's nice. So when people say they don't want to lift weights because it's dangerous, no. And they don't want to lift weights because they don't want to become Mr. or Mrs. Olympia, don't worry. It's not even going to happen for everybody who's purposely devoted 20, 30 years of their life to do so, and they're not even close. So I think you're going to be okay.
Brilliant. Nailed it. That was literally...
Was that within 5 minutes?
That was 5 minutes and 30 seconds. Fantastic. Hey, a follow-up question.
Yep.
I loved how you talked about, you broke it down at the end there and said, hey, well, where's the starting point for some people? going further down that rabbit hole, for people that are listening to this podcast and they enjoy listening to it for the clinical aspects, right? But here they've clicked onto this podcast and there's so much focus on strength training that's going to be coming through on this pod, yet they may be highly sedentary, overweight, obese possibly. Where would someone like that start, in terms of overall health, getting them into resistance training? Where would you start someone like that?
Okay, so 10-minute walks after meals, tons of research behind that. If you don't know that, just look it up so I'm not wasting time. Get activity levels up, right? I don't have anybody who's severely obese or overweight or unhealthy do any sort of interval cardio because we got to get your cardiovascular system up. So I reserve that to once they've kind of gotten the ball rolling. But I think 1 day a week of some interval cardio is spectacular for a variety of benefits. For resistance training, first of all, you don't need to be a bodybuilder. You don't need to do 50 sets, right? You don't even need a quote unquote bro or pro split where it's one body part a day. Like if you haven't done anything for a long time, it might be body weight only, squats, super light, presses, rows, whatever. Typically start with only 1 to 2 working sets. Who don't care about load, care about execution, get your form down, be consistent. Because if you make somebody so sore they can't walk for 14 days, which they're going to get crazy sore regardless, the odds of them doing it again are slim to none because they have T-Rex arms and they're crash landing every time they have to get on the toilet, and then that hurts, right? So big compound movements. I don't think you need to train your arms even, right? Like do a squat pattern one day, a leg curl one day, the next maybe do a hip hinge if they could do it, and a single leg movement. One arm rows, I think those are mandatory for what it does besides just hypertrophy and strength. It's the world's one of the best core exercises ever. Do some presses, probably do something more upper back focused to help with shoulder blade mechanics. So face pulls, a variation of that, or whatever you want to do. But keep it simple, 1 or 2 sets, 10 reps, start out from there, 1 or 2 days a week, slowly ramp up, earn the right to be able to do more exercises because every exercise is a skill. And make sure you don't completely cripple them day one because they ain't coming back.
Brilliant. Yeah, really good.
Nailed it.
Yeah, I thought it was fantastic.
Thank you.
Really good.
Yeah,
well done.
100%. Yeah.
I think from a manual therapist perspective, from a manual therapist perspective, I always try to emphasize that what the patient does off the table is more important than what we do on it. And you just can't, and if the patient doesn't want to get involved in some form of physical activity, you can rub it, wiggle it, whack it, and spin it as much as you fucking like, but you're you're flogging a dead horse. They have to, what they're doing off the table is so more important than what we're actually doing on that 30 minutes, to be fair.
It's interesting that when you look at the literature, people often discount just physical activity. So not looking at exercise or resistance training, but literally just looking at how much you do over a 24 period of hours in the day. And obviously that's very limited in terms of certain things, but in terms of all-cause mortality and things like that, the power of a clinician to just educate and get your patient moving more, that is a fantastic on-ramp to doing more.
What's tied to mortality? Grip strength and VO2 max. We're designed to pick stuff up. Yeah. We're designed to move a ton. Like we have no tool, we have no teeth, we have no claws. We walked animals to death. We would sprint for long, short distances. So we're designed to move a lot and pick stuff up. Yep. Exactly. So, and I'll tell people, fine, I don't care if it's swimming. I have a couple of people who are severely overweight. They're unhealthy. They're not going to do resistance training, but they're at least going to a pool and doing water aerobics twice a week, which is a massive change. That's awesome. Like, because we need consistent adherence to a subpar program, always outperform sporadic adherence to a so-called perfect program. Nothing exists. Just find something that they will actually do and let momentum build. Momentum's positive, both positive and negative. So if you can empower them, and I've had the conversation, I'll end with this because I don't want to make it too long. I've had the conversation with patients of, I think you might be better off going somewhere else because how my model works is you only come in 1, maybe twice a week. And if you're not doing the stuff I'm asking you to, if you want somebody who's more just going to do the constant manual therapy stuff, let's find you, and I'll give them a couple other options. Yeah, I've literally had that conversation. 2 people never left. 3 people had a complete change of heart, and they are killing it. And they're actually like, I squatted for the first time in 10 years was the message I got 2 weeks ago from one of those people where I had to say, if you're not doing the outside work, this ain't going to work.
Yeah, I love that, eh? And what you were just saying there before that, Giles, about anything can be exercise or physical activity. And that's the crazy thing when you look at some of the epidemiological population-based data and you see people who are sedentary and they're active, they have isolated effects. You can train for an hour a day and you can sit all day and you're still going to have the negative impacts of sitting. It's hard to unwind. Like from a musculoskeletal standpoint, you can 100% you can work on reversing things. But from an overall global health point of view, you can't just do one without the other. That's why I think it's important to also preach physical activity. It's literally just verbiage, exercise, physical activity, but it's just be more active is kind of what I was trying to say. Yeah.
I was going to say, Io Ludeman published a book last year on exercise prescription, and it was basically about creativity, just giving the patient something they can do. If they can't go to the gym, they can do something at home, picking up the shopping, doing a walk, and tailoring it to the person for the general population. Doing something is obviously better than doing nothing, even though there is a very poor compliance in actually patients doing the exercise rehab. But that's where education and creativity comes in and is key for it. So I'm a massive component. I would always say sometimes it's much more valuable for the patient to, rather than pay me as an osteopath, pay for a gym membership for a month. I'd rather them do that. Yeah, don't waste 150 quid to see me for 30 minutes. Spend that money and go to get a gym membership for 30 days.
Yeah,
and you'll probably get much more better results.
Yeah. What a humble, selfless thing to say, you know, coming from a manual profession.
I'm rubbish. That's why, to be honest.
Well, I'll have patients do Post-it notes. When they brush their teeth, they've got to do their rehab exercise. If they open up the fridge, they've got to do 5 air squats. Like, that's cool. An easy way to build stuff in.
Yep. Sorry, Dre, did you have a question?
Yeah, I was just going to say, like, the injury rate of running for novice people. There's one thing that, like, a lot of people, when they come into this conversation about strength versus whatever, running versus swimming, when it comes to injuries, is you have to look at the why. Just like how all-cause mortality is correlated to upper limb or grip strength in men, and lower body strength in women. Yeah. That's partially due to hip fractures. So if they are most likely to be osteoporotic when they have falls like that because they lose their balance, that's automatically 5 years death sentence for a lot of our population. And for men, it's because they're tinkering. So when you look at why you're choosing something and you're looking at the injury rates of it, you also have to keep in mind why those injury rates might be there. For novice runners, it's usually because they don't hit that neurological stimulus often. So they usually have poor force transfer. They usually have really bad running mechanics. And they're just constantly just kind of like falling in style. They run like they're running on a treadmill, which is literally just duck slapping. And force is just going every which way, which over time, if you're not even good enough at running, how are you going to know how to recover as well or take care of yourself, do the mobility, do all these things to help keep your tendons and tissues decent at the very least. So it's like, throw them in a pool, teach them how to run there. If they have a constant resistance of water around them, the odds of them still running like they're on a treadmill on land is much less. Put them on a bike with about 90-95% full knee extension. That way they can actually feel when they're turning on, when they're overusing their quads. You can literally track them when they catch a leg cramp if they're one dominant more than the other, whether it's anterior or posterior. It's little things like that you can, get really creative with and still be able to trick people into taking care of themselves. I mean, that's my number one goal in life, is tricking people into activity. I mean, I can't tell how many times I have people standing on one leg brushing their teeth. And they're like, oh, I can do this a lot better now. And they find themselves brushing their teeth for 5 minutes because just try to see how long they can stand. So their dentist must think I'm awesome. But at the same time, they're also increasing their ability to protect themselves falling off a curb or stepping off a curb, right? So if you're trying to have adherence with working out and trying to avoid risk of injury, you have to keep it interesting to the point of where they always want to push themselves. And I don't have to be a coach. Accountability buddy is where I draw the line. I don't want to coach anybody.
For those of you that don't know Dre's background, he's an all-American track and field athlete. That gives you a really unique perspective, and I think it's really shaped how you have gone through your educational years. You tend to always bring a really cool, fresh take to things. You almost just did a myth bust right there, but fantastic points from everybody and great follow-up questions and great myth bust. Dr. Marv, awesome job. So we're moving on to yours truly. All right, I'm going to start the timer. So I am talking about my myth is all around fatigue management. Busting the age-old myth of, oh, bro, your CNS is fried after training heavy as a powerlifter. I'm sure you've heard kind of meathead or every coach kind of say that to the athlete or every powerlifter. I said it all the time. After a hard training session, 12 weeks, getting ready to kind of supercompensate, I would be saying, oh, my CNS is just whacked. Or, after a big, heavy deadlift session, just one session, oh, my CNS is going to take longer. So that's what I want to talk about today. So really what we're talking about is fatigue management. I think we can all agree that it's important for an athlete not only to be able to manage their fatigue, or a coach, but to also be educated around thus fatigue. And that's why I think it's important we are discussing this. Over the years, there have been some strong views that have been perpetuated that I think are not fully correct or wrong. And some of the research we have now does kind of conflict some of these previous beliefs. To start it off, let's just talk about fatigue. General description: reduction of physical performance, inability to maintain strength due to decline of force output, also perceived to the feeling of difficulty. All right. Fatigue is associated with hundreds of disorders. And one important thing that I want to state from the start, it doesn't always fit into a scientific neat box. It can be complex, complicated, hard to understand. It can have physical, neurological, psychological, emotional, various dimensions of fatigue. And that's something that we need to understand as coaches. Why is it significant? It can harm you, right? It can affect your performance, your output, your stamina, your neurological, your physiological. Why is it a problem? If we take a step back and we look at it broadly in terms of population, over 1,500 US fatalities, 76,000 injuries, 100,000 motor vehicle incidents, all annually because of fatigue impairment. If we take a step back, so it matters. And obviously it matters when we're lifting weights too, as I said before. Technical ability, technical prowess, performance, output, all of the above. It can influence injury. When we look at central fatigue versus peripheral fatigue, we know more about peripheral fatigue in the research. It's very easy to mistake one fatigue for another, and it's very easy to be black and white and blame one fatigue for another, which I think can be problematic if you're a coach. Central fatigue, the literature often describes it as cortical output, neural drive deficiency, which is going to attenuate performance or inhibit physical activity. We're talking about CNS fatigue, neurotransmitters, serotonin, dopamine, glutamate, GABA. We're talking about the brain and the spinal cord. Peripheral fatigue, we know a little more about in the literature, manifests through the reduction of muscular efficiency due to metabolic or biochemical changes. Potassium ions, inflammatory cytokines, pH levels, sodium, potassium, calcium, accumulation of phosphates, etc. In simple terms, fatigue that is related to your muscles. All right, just get that out of the way so we understand what we're talking about. Once again, it's complex. Fatigue is complex. Billyon's ETL 2021 review described fatigue as multifaceted, multifactorial, a multi-dimensional construct. Now, without swaying into pain science too much, because I can't do that, it is important just to understand that, yes, it can be complicated, right? He reported up to 8 possible different fatigue dimensions: physical, mental, cognitive, central, peripheral, emotional, motivational, and psychosocial. I think every single one of us that is in this podcast has trained hard before. Some of us in this podcast have been elite athletes, and we know emotional and psychological play a role in your performance. It absolutely does. For those of you that aren't maybe powerlifters or in the strength industry, the most common kind of belief or the ideology around central fatigue was that it was the slowest to recover. Okay, so it had the largest SRA curve, stimulus, recovery, adaptation. It got blamed. See, the CNS fatigue got blamed for a lot of shit in the training world. Many kind of believe that the ramifications from a hard workout or hard training could have 2 to 3 weeks recovery. And leading coaches to this day, leading coaches in the industry will still tell you that neural fatigue has the deepest fatigue debt and the longest recovery time. With the research, we look at it a few ways. This is how we test it, right? I know Locke's going to like this one because he loves to break down research. How do we test it? It matters, right? We can't just look at reviews. We've got to understand this. Well, old school, they did a vertical jump, shotgun method. Did it work? It had its benefits. It's also inaccurate. More recent research looks at EMG, electromyography, so that's nerve conduction, electroactivity, muscle and nerves. MPE, motor evoked potential, so that's the integrity of descending anterior columns of the spinal cord. And MVC, maximal voluntary contraction. So they would use those to simply differentiate between cortical drive deficiency and the muscular system's capability to contract and exert force. Okay, so we're probably wondering at this point, what causes it? What doesn't cause it? So 2016 study of heavy biceps training. Now, I know it's biceps, but hear me out. Heavy biceps training, the CNS neural excitement returned to baseline completely after only 20 minutes. Now, that's a lot shorter than what we would usually expect with our normal supercompensation model of 24 to 48 hours. However, it's an isolated movement. I understand. Let's look at something a little more gritty. Squats and deadlifts will do. Barnes ETR 2017 compared to deadlift and the squat. He was trying to prove that the deadlift was actually harder or that it had a longer fatigue debt. And he found out that it was the squat. Nonetheless, he had participants doing 8x12, 85% of max, both squat and deadlift, heavy, grueling session that you would be walking upstairs limping, telling your buddy when you're going to get a coffee, oh, my CNS is fried. Very, very little CNS fatigue was shown. Latella ETL 2017, when comparing hypertrophy with strength training, found the same thing. little CNS fatigue was found. So what causes it? Well, they did a 70-minute long, slow bicep contraction at 5%, and that seemed to do it pretty well. Thomas ETR 2015, they have done quite a few cycling studies for Mo. I know you were a very good cycler in your day. Studies for cycling, kind of low and slow. They found that peripheral fatigue exacerbated with exercise intensity. CNS fatigue was exacerbated with duration. All right. So we're starting to see a pattern here, not just with one study, but multiple studies. Yoon, ETL 2007, low force tasks created more CNS fatigue. 2015, another study, cyclists did 2 20-40K cycles, more CNS fatigue with longer, low intensities. All of this research, we're starting to see a pattern. In simple terms, think marathon, CNS inducing, powerlifting, peripheral inducing, right? So intensity versus kind of low and slow. Is this the be all, end all, and the final take on it? No, this is just we're looking at research from the last kind of 10 years. Just coming around and finishing up and concluding, why does it matter? Well, I think it can impact an athlete when they think something's happening that may not be happening, or as a coach or an athlete, when you're attributing something to one thing when it is actually another. I think it can change how you are going to manage fatigue, and it can change how you interact with your client, or how the athlete interacts with lifting. So many times I went in after squatting 400 kgs and I'm telling myself I'm tired, strength is down, maximal output's down. You know, maybe I wouldn't have thought that strongly if I was thinking of it more as peripheral. Obviously, proper fatigue management is important for performance, as we talked about before. And I do think it can impact not only mental and physical stamina, but force production, technical ability, movement quality, exercise tolerance, neural drive, reaction time, proprioception, and it can put the athlete at risk. So here are my takeaways as I finish up. Number 1, don't fear CNS fatigue, understand it. Number 2, the fatigue you do experience is likely a combination of all fatigue dimensions. Number 3, following hypertrophy or strength training, most of your fatigue, however, is probably neuromuscular or peripheral. Number 4, heavy deadlift and heavy strength training is likely not a major contributing factor to CNS fatigue. And number 6, we want you to focus on evidence-based general fatigue management protocols. What are we talking about? Load, capacity management, quality rest, sleep, nutrition, and hydration. That is the end of my myth bust.
Did you get the memo on the time limit?
It's nice when you make the rules.
Yeah, exactly. I mean, rules
okay, so I've got a question across the board. How do people even attempt to monitor it?
Absolutely.
What do people use on here?
Well, HRV is easy. HRV is something, 10, 20 years ago, it was you had to be a sports scientist or you had to have proper machinery to do it. This day and age, you can go out. You don't even have to buy an Apple Watch. You can go out and buy a fake watch, $20, and you can look at your HRV. It's something I do with as a strength coach, I did with all my clients. Now, it's not just that. It's about asking the right questions as well. I had clients turn around and say to me, why are you asking me about my relationship with my wife? Well, I want to know. I want to know if you've got emotional fatigue elements. Now I'm not a psychologist. I'm not a pain scientist, but it's just one small aspect of a bigger pie. And so there's multiple subjective, but also objective ways to track it. HRV is a good way. And then obviously load management and capacity of your athlete as well.
Actually, it's very interesting is to find the athletes who need to have exceptional adverse conditions in their life to be able to perform at top level. So I know one spectacular world champion, and when the police are after him, when his ex-wife's chasing him, probably going to key his car, and everything's absolutely screwed, the business isn't paying the bills, and everyone goes, okay, there's no chance he's going to be ready. Yeah, that's the time he breaks every freaking record. He needs adversity.
Yeah. Mm-hmm. Amazing, isn't it? Amazing the psychological impacts it can have, right? Especially when you get these outliers, you get these people that break the rules, you get these people that come out and they just, I mean, the story you told about Milanishev tearing his tricep, in my mind, I'm thinking, physiologically, biomechanically, it's impossible in my mind that he can come out and bench again and get that lift. He did it.
Blows minds.
It absolutely blows my mind. Okay, well, hey, my apologies for going over. Let's head on into the next one. I'm looking forward to this one. Matthew Lewis, take the floor.
All right. Yeah, so in the U.S., if you have a chronic musculoskeletal pain condition, you are more likely to be prescribed a medication than be given a rehab protocol. How do I know that? Well, study published in 2020, they looked at 12,000 visits of a patient presenting to either primary doctor orthopedic doctor with the initial visit for a chronic musculoskeletal pain condition, 40% of the time they get a non-opioid medication. 20% of the time they get an opioid. 15% of the time they get counseling. 10% of the time they get a referral for physical therapy. And then another miscellaneous category, 14%, they get other non-pharmacologic treatments, which is probably chiropractic, acupuncture. That means over 60% of patients got a prescription for their chronic musculoskeletal pain condition on the first visit. And twice as many patients got opioids and got a referral to physical therapy.
Whoa.
So all of you as rehab professionals, you should be hearing this and be like, wow, that's cringe, you know? That gives you an idea of how physicians in the US treat musculoskeletal pain conditions. And from a patient perspective, I had a patient, I worked in a pain clinic. I'd see 30 patients a day handing out opioids. I didn't know any better. This is when I was getting into McGill and all this stuff. And later on, I had a patient, I convinced her to do a McGill assessment. She was on opioids multiple times a day, getting injections, had her do a McGill assessment. I taught her to move pain-free. Everything that used to cause her pain, she's now moving without pain. All her activities of daily living, getting up and down, lifting something up the floor. Every moment was like an aha moment. Like I could see it in her eyes. Oh, I used to do that and it was painful, and I do it this way, it's not painful, just with movement proficiency. So it was great. I was like, this is wonderful. Like this patient doesn't need to take opioids anymore. This is fantastic. Because if you can do your everyday activity without pain, then why do you need to take pain meds every day? Your pain can slowly desensitize and be, cured, for lack of a better term. So I was ecstatic. She was less ecstatic, which was confusing to me. And then months later, she's asking me for more opioids and more injections. And I say, well, what's going on? And, work got stressful. She stopped doing her movements, her exercises. And I was just thinking, like, what went wrong in her head? Was it laziness, that this was the easy way? Or was it an underlying myth? Underlying myth that both the physicians believe and the patient believes, that oral medications, injections are more effective than movement, exercise-based techniques for chronic musculoskeletal pain conditions. Whether physicians believe that or not, they act like it is true because you act on what you believe. I mean, this myth is obviously false. NSAIDs cause gastric ulcers that bleed, cause life-threatening bleeds, kidney problems, increased risk of cardiovascular events. Opioids cause osteoporosis or penia, increased risk of infections or cancer, addiction, hypogonadism. And when you stop taking them, you're back in the same place you were before. So obviously, it's so false that it doesn't even require debunking that these medications are not more effective than exercise and rehab. But I was wondering, how did we get to this point where these patients and clinicians are believing this myth? And I think it comes down to the fact that physicians aren't stupid, patients aren't stupid. They've seen therapy, they've been through therapy, and it didn't work. Why? They've had non-specific therapy, and it led to non-specific results. Their therapy didn't involve biomechanics, injury mechanisms, biotensegrity, regional interdependence, neurodynamics, functional movement patterns. Talk to therapists, physical therapists, they'll say, oh, we've been through that period of stage time where we did biomechanics and it didn't work. And I'm like, I call BS on that, because ask them, how they teach a patient to stabilize their spine, and they'll tell you a drawing in maneuver. So that immediately you didn't do biomechanics because you don't know what you're talking about.
Yeah.
And this is across the board, not just for like back pain, but impingement syndrome or patellofemoral pain syndrome. To the next point, I can't tell you how many patients I've had in my pain clinic where they've already been through therapy and they still have their chronic pain that they still have. The end result is the patient's got a lazy assessment and a lazy rehab protocol. So you have non-specific results. I have this little comment to myself: don't be the agnostic clinicians that say it's impossible to know. You just can't know as far as like determining what is actually causing pain. You just ask them, well, how do you know that you don't know? And then you just debunk that myth. But all of this, actually, the underlying myth to this myth is the fact that all patients can get better with a non-specific rehab program. And when they don't, it's time to move on to the next level, which is not a more specific rehab program, but meds, injections, and surgery. I think that is playing into the current myth of overprescribing.
Being in a pain clinic, you prescribe meds, correct?
Yeah, I'm no longer there, but yeah, I was prescribing opioids all day.
How did you balance prescribing opioids versus being a McGill certified practitioner?
Yeah, I would say I described every day as like an existential crisis. I don't know if you ever heard of Martin Luther. He was like, before the Reformation, he was like upset with like the Catholic Church, and he had an existential crisis where he was like, the world is wrong. There's something wrong with the world. This is not right.
Yeah.
And so that was me every day. And so as I've explained to you, Brogan, before, but other people may not have heard, I'd really try to pick out patients that I feel like this patient's going to listen to me if I tell them, you don't have to just take opioids all day and be in chronic pain all day. And the ones that I could convince them to believe it. For the one patient I mentioned earlier, I thought I could convince her, but apparently I didn't convince her because that myth was so ingrained in her head that, I wasn't giving her the real solution. The real solution is medications and injections and surgery. I was giving her, actually in her own words, tips and tricks.
Wow.
Because she wrote a testimonial about me and said like what I gave her was tips and tricks. And it's like that myth is so pervasive, not only geographically, but in her mind, that medication was the answer. And you might say it's laziness, but I think it's an underlying belief.
That's amazing. You said, convince them to believe it. I mean, just, for us rehab clinicians, therapists, hearing that, it's insightful to hear it from someone that's kind of been behind the curtain, so to speak.
Yeah, because it's not their fault. Like, I don't blame the patient. They've been through therapy that's bad. Why should I be any different?
That's a classic one Matt has there, which is important, is actually the failure there really is upon us, that we didn't communicate how powerful what we did is. And that's the thing I'm still developing and much more aware, I think, over the last couple of years, is even the dosages. I have to explain to people that the dosage of exercise prescription is like dosage of medicine. You can overdose, you can underdose, and to be actually really bring in how freaking important the precision of our dosage is. So yeah, it's a huge thing you bring up there, Matt, is we have expectations that the patient will feel better, therefore they're going to do it. Oh my gosh, you've got to get into their, unscrew their skull and really get in there to be able to know what makes them tick and how do we communicate that to be effective. It's a tough one, but that's my biggest takeaway even from the US tour, watching really top professionals who I go, oh man, they're just so damn good at communicating.
That's fantastic. Hey, fantastic. Sure. Really good, Matt. Really, really good. Awesome to hear your perspective, and it added a ton to this podcast. So thank you for bringing your perspective and busting that myth that to us seems obvious, but to some people listening to this, probably a lot of people listening to this, is not obvious, So that was awesome. We're going to throw to Luke Gichard, one of the brightest, most talented young minds in New Zealand, soon to be abroad. I won't say where because I think it's still confidential. Luke is going to be touching on unethical x-rays, and this is something that many of us here are very passionate about. I think I've almost seen all of us talk about it on our own social medias at some point. Not to mention various people in this chat are co-authors on the paper that is being, I don't know if I can even talk about it. Can I, Giles?
Yeah, if you want to.
Yeah, which is going to be published in the upcoming book that we're working on with Giles. Fantastic book looking at various modalities and taking them from what people think they are and kind of old school and bringing them into this new school. How can we use it in an evidence-based manner? And part of that is looking at how we use x-rays when it comes to postural misalignments and, should I dare say, subluxation.
So the unethical x-ray sounds like a chiropractic comedy troupe.
Maybe it is. Maybe it is. So Luke, this is a big topic. I'm sure you've got lots to say, so I will start the timer and the floor is yours, sir.
Yeah, let's get it. Yeah, let's kick things off with this. This is a subject I'm passionate about because I've been dealing with this fucking bullshit for the last 5 years and still So sorry if I start projectile yelling across the screen. But just as a disclaimer, we're myth busting unethical x-rays for postural reasons and misalignments, fully endorsing the use of x-rays for red flags, right? So
Yeah.
kick things off, we're going to look at the diagnostic validity of these x-rays for postural misalignments, and there is no evidence between the cause and relationship between symptomatic patients and radiographic findings. There was a systematic review done in 2015 that consisted of over 3,000 individuals, and many reported asymptomatically, even though there are multiple of radiographic findings found on x-rays within these individuals. So disc degeneration, disc bulges, facet degeneration, and certain types of spondies, right? And there was also no evidence to suggest that diagnosing these asymptomatic patients based on radiographic findings will alter how these are managed in a clinical setting once a thorough history and physical examination has been done. The sort of key takeaway from that point is why are certain, clinicians and especially chiropractors routinely taking these x-rays to diagnose an individual's pain when there is no direct correlation. So we look at, is this really in the best interest of the patient to exposing them to unnecessary radiation? Even if it is minimal, it's still unnecessary, as well as, financial strain, especially within the economy in this day and age in New Zealand. So that key takeaway point is treating the patient and not the image, right? Looking at and understanding movement proficiency. The second point, the use of unethical use for postural misalignments, right? There is also no correlation between postural misalignments and pain. A study included 762 individuals trying to link cervical symptoms with sagittal cervical alignment on x-rays. And they concluded that there was no correlation. And another separate study looked at and found no correlation between spinal trauma and postural curves. Key takeaway from that point is that postural misalignments are not pathological. They're likely to be a normal variant in everyone. When it comes back to the evidence-based practice that we've been taught in college and the academia, again, is this in the best interest of the patient, and does it consider the best available research? Because if the research isn't there, then why are we bothering with it? Moving on to point 3, this is a point that I love. It's looking at the accuracy and practitioner inter-examiner reliability of these x-rays, right? I've noticed that many chiropractors, they love to pride themselves on specificity and accuracy. Now, I'm not talking about being specific with your history and your physical examination, but I'm talking about being able to move one bone from out of place back into place, okay?
Bullshit.
And I believe this is what they think that separates themselves from other professions, and it kind of gives them a sense of identity and worth, if that kind of makes sense. Yet it's ironic that they'll use line analysis to deter misalignments and postural curves based on a static image, right? So for you gondroids that might be listening now, throw away your goniometer and your nervoscope and focus on the movement with the patient, right? Because I tell you what, the factors that influence the static imaging is crazy. There's a lot of them, right? So it's patient positioning, patient physical and morphological changes over time, hydration levels, sleep, doctor inter-examiner reliability. All those factors will influence how the wedge is sitting right, on the image, okay? So forget it. And the last point that we're looking at, although we've established that no correlation between symptoms and radiographic findings, yet many chiropractors still use these images and x-rays as scare tactics or to fearmonger their patients into long-term treatment plans. A common one that I see, or any of you guys out there listening right now, if you walk into a chiropractor's office and you see a model of the phases of spinal degeneration sitting on their table, fucking run away. Run away, right? At the end of the day, this can negatively influence a patient's overall emotional status and self-efficacy. This can lead to fear avoidance of certain physical activity and daily activities throughout their life, and it can potentially result in chronic pain until they have felt that these radiographic findings have resolved. And a family member of mine has actually just gone through this process with one of their doctors. She had actually been told that she had all these findings on these images and that the only thing that was going to help her was getting a lazy boy to start immobilizing herself and start wearing a neck collar. So at the end of the day, it's these scare tactics that are being used without in the industry.
Fantastic, Luke. I mean, I think I need a stiff drink after that, a vodka. But you got my blood pressure up. Just I wrote down here, functional movement diagnosis. What happens when someone comes to Lock with an MRI? He tells them to put it in the fucking corner.
I just had a message from a patient just then, and they're coming to an appointment tomorrow. Do you want me to send the doctor's letter and the report now? I go, no, the appointment starts exactly when I told you it starts. Don't send me anything before it. I'm charging you from the moment you walk in. And put your scans away. I'm going to do the assessment first.
As you say, you treat the patient, not the scan, right? It's giving somebody I call it a functional movement diagnosis. And it's so easy to get caught up with the pain. We'll be talking me and you'll be chatting, Locke, about stuff, and sometimes you'll pull me up and go, hey, you're focusing too much on pain. Remember, take a few steps back and let's talk about function. I think that's something that is hard to keep yourself accountable, even for the ones of us out there that are trying to be honest and do things ethically, because there are chiros out there that will purposely draw up red lines on vertebrae and make things look wonky, and then they'll say, hey, this trauma has happened because you've done this and you've done this, and you need treatment.
I was just going to say, do you think that is this actually taught on the course, Luke? So, I mean, they're teaching you to do X-rays. And
yes.
not teaching you.
I was going to have the same question, because as osteopaths, I don't know about you, Mofo, we weren't taught to take X-rays, or we were taught to sort of review it for sort of red flags. As an osteo, we were never taught to use X-rays for diagnosis.
Is the X-ray being sold as a money-making machine? It is kind of how it comes across. So as a chiro student, they're saying, do these X-rays, you make lots of dollar, and you can tell.
When I was in school, they told me, you put an X-ray machine in your office, you'll pay it off within 6 months, and you'll be able to buy whatever car you want in another 6 months from X-ray alone. So this is why you should do it.
So it is basically driven by.
It's forced down your throat. Like they are severely subsidized within the institute. So, for example, they'll always push for a full spine X-ray, which is about 90 NZ dollars, versus if you were to get referred externally, there are a couple of hundreds. But because we're required within the college to put people on certain techniques, such as Gonstead and upper cervical specific, those mentors that push that narrative or that abide by that technique will kind of put you in that corner and try to force an X-ray down your throat to better analyze, essentially.
Is that because they believe that's the best way to go? Or is that because
the practitioners, the mentors on campus that follow specific Gonstead protocol, that's what they do on a daily basis, right? They full spine X-ray everyone without fail, so then they can look at the static image, rule those certain vertebrae up, and adjust based off that. So there are ways to get around it, and when you get into your final year, there's a bit more leniency. If your case isn't approved, like if you push for no X-rays and the mentor is biased towards X-rays and they won't approve off your case, you can essentially go sort of higher up and kind of argue that. But yeah, unfortunately it is pushed. We do rotations every semester on actually taking X-rays. We have a chiropractic radiologist on site, obviously, that's watching over us, and we actually have to set up the patient. We have to move around, the bucky and things like that. Again, it's just those hurdles that we talked about, right?
Yeah, so for you, Mo, chiropractic has, as a profession, has always been very linked to X-rays compared to, say, like osteos. They do have training on it. We had multiple papers on not just radiography in terms of how to read it. Every chiro here knows this, right? You guys have all been through it, but also how to take them. And then you get encouraged to have one in your office so that you can upsell people, you can make money, you can use it as a tool. So they're doing exactly the opposite to what you do. And when you talk about integrate and isolate, it's even worse though than isolating on like a certain movement. They will literally isolate down on a 2D superimposed image, not even an MRI, an X-ray image. McGill will say, you look at a moment in time, an X-ray, and it's like wrinkles of the spine. You see these things. I like wrinkles of the spine. It's the opposite. They'll say, okay, this here, this disc thinning, this degeneration. They will zone in on what they see, and then that will guide the process of their diagnostic assessment. Some people will claim it doesn't. And it's hard we don't want to paint every chiropractor with the same brush, because this is a certain part of chiropractic. The chiropractors that are in this chat are not like that at all, right? But I just wrote a very large paper that's going in Giles' book about Gonstead. Gonstead was one of the people that part of his treatment protocol was that he would do full spine X-rays. And then he had a bottom-up approach, meaning he would look at the pelvis first. He would make these outrageous claims that even if the patient's asymptomatic, or say the patient is a kid and is bedwetting, or is having colic or having reflux, Gonstead had vertebra and misalignments that he would correlate on an X-ray to those symptoms and then adjust based on that. So they're not getting people to do functional movements. They're not doing appropriate assessments. They're not doing movement. Luke would be expected to give his results to the teacher to get signed off. And, okay, what's your joint play? just pushing the bone? What's the joint play? They do some motion palpation, but even the motion palpation is strictly Gonstead and has very little utility compared to some other styles out there. So it can be pretty grim for some people. Now, you know, legends like Dr. Marv, legends like Dr. J, legends like Steven, these guys are like, you know, pretty much outliers in their field. And it's different in America. I can't speak to the world. New Zealand is dominated by one college and one philosophy, which is an old school one. It's a very old school. In the States, there are a lot of forward-thinking chiros. They do things well. I'm sure any chiro that's in this chat could probably speak to that better than I could.
But one of the things I think about there too is, was Gonstead actually just being honest? He wasn't doing that to make a shitload of money. He actually believed. He believed
He
in
was.
his theory. And
100%. Yeah,
there's an integrity to that. There's an integrity when you're making it your belief and you're having a crack at it, and you differentiate that well to the others who are just using it as a financial scheme to get rich. I think Gonstead wanted to change the world. Yeah,
he was a rock star. Gonstead was a rock star.
And I think that's what I was struggling with. It was the concept that they were teaching stuff that was falsified, whereas Gonstead believed that this was
They also believe it.
The way of treating things. That was his philosophy. Yeah.
They also believe it. And me and Luke, we did a deep dive into Gonstead before we even took the paper. We read the entire book, and I've got it all. I just wrote a massive thing on it for the book that we're doing with Giles. But you know, he was really ahead of his time. You know, at the time, BJ Palmer was preaching that you adjust the C1, C2 atlas axis, you know, to restore nerve flow to the rest of the body, and he was almost forcing people to do what he wanted, hole-in-one technique. Only along comes this rock star that's doing full spinal side postures, and knee chest, dropping down on people's backs, thoracics, P-Day, and thoracics. He's freaking a rock star. He's got the cervical chair. He's rocking people's necks. I mean, in some ways, he came in, he changed the game. He gave people an opportunity to practice medicine, chiropractic medicine in a whole new way. Many smart people have said to me, if Gonstead was here today, he would be more like a Mark King or a Corey Campbell or a Stephen Redmon or a Dr. Dre or a Dr. Marv or a Giles. You know, like that's more like where he would be, because he would change with the times. But people are stuck in this 1940s snapshot. And I think that's where the damage comes from. And then you also get people that just want to make a buck off it.
I mean, the techniques are valid, but the philosophy's changed.
Exactly.
Yeah. Which it's a bit like osteopathy, Giles. Again, we're still stuck in the 80s, stillion days of.
The problem is with these professions, osteo and chiro, you can have very, very people become obsessive about the philosophy and the history of it. It almost wraps up into their virtue, their identity, and you challenge their identity. You challenge them personally. You know, everything's contextual. It's interesting to have a history, but the reality is it's 2023. Is the relevance there anymore? The techniques are great, but let's bring it to a modern context. Let's use what we have, the evidence base. Let's add in other professions, bring it together. But people love history because it becomes who they are, and then you challenge them as an identity, and you're challenging their sort of virtue, and it becomes a difficult one, very difficult.
People love history except pain scientists.
You can't read a paper that's older than 5 years. You can't read a paper.
Wouldn't it be nice if we all just amalgamated into one profession, save the confusion for the public?
Believe that's where it will go, mate. Give it 10 years.
It's a doctor of manual therapy. Yep.
Yeah.
I think there's more similarities than there are differences, and that's the problem. A lot of people can't handle between the professions. There's more similarities than there are differences, and unfortunately, having a unique identity in 2023 is where everyone's trying to find a USP.
Purpose, is it?
Not really. No, the treatment is about the patient, not about the ego or the individual.
Yeah,
it's a difficult one.
Lose your religion.
I failed a first year paper writing about that very thing. They asked us to write our future vision of osteopathy, and I said we'd join with physios and chiros and just form one therapy. I failed that paper.
You were ahead of them.
Yeah. You don't write about the narrative they want, man. They put a bullet to your head.
Yeah. Yeah, 100%.
I guarantee you change your diagnosis depending on the tutor you're talking to as well. Yeah. And that's the problem. 100%. It's just that university, unfortunately, is a bit of a sham. It's a bit of a fraud. You pay, you tick the box, you smile sweetly, and then you get the fuck out of Dodge.
We have like an open plan area in clinic where we have like 15 tables on one floor. There's like there's nothing separating patient confidentiality. It's all just a business scheme. And then you have like mentors who are like prison guards walking around, you know, making sure you're following all the rules. A lot of the time it's stepping on eggshells, eh? It's just not worth it.
Once Luke graduates, because I've spoken about, you know, people that have been in college doing, you know, student treatments out back and getting patients better. You know, we don't want to say names because we people that are still studying, we don't want them to get in trouble. But once Luke graduates, we're going to do an episode where we talk about all the kind of bullshit that went on during those years. I think it's going to be funny. Next, we're moving over to the Tony Stark of chiropractic. He's got the shades on all the time because he's cool. No medical reason. No, there is a medical reason. I'm looking forward to hearing you chat about this.
So my myth is manual therapy like has to hurt. Manual therapy has to suck in order to be effective. That is entirely inaccurate and complete bullshit. Just to put some preface into it, or to start with the baseline, I do teach at a massage program, and when I went through school, and even while I'm teaching at school, like we say manual therapy shouldn't exceed a 7 out of 10. And people come in all the time with like more than a 7 out of 10. Or they come in less. And if they come in less, why would you inflict more pain on them to get them better? And if they're already really irritated, why are you going to potentially exacerbate their symptoms? It makes absolutely no sense. Like none. You want to talk about CNS fatigue? Imagine the mental and emotional drainage of preparing to go see someone who's going to beat you up. You're going to pay them $100 to beat you up, and then you not feel better. Like that's some CNS fatigue. That's absolutely some CNS fatigue. That's some psychosocial stuff going on. Like I don't get that. I mean, yes, at times there may be discomfort. At times it may be a little bit too much. And you reel it back in. Like there's nothing wrong with dropping an elbow on someone every now and then, but you're not going to do it until they're bruised, or you're not going to scrape the shit out of them until they're black and blue. There's no clinical rationale behind it, but people still do it. I've seen people like do these webinars where they're like talking about, oh, I'm doing the scraping CEU, and then the very next day they take pictures of their patients, and their patients are black and blue. Like you were literally just taught, because no one in 2023 tells you to bruise your patient, but it happens. I don't understand why it happens, other than history. Like people said that's the way you had to do it a long time ago, and they're just like, oh yeah, I got this brand new information thrown at me, and I'm going to completely ignore it and go back that way and just hurt my patients for a living. I mean, it will help them come back unless you scare them away, because if they're still hurting, they're going to need to come back. It's beating your patient up is not going to make them get better. And then we can talk about more of like the spinal manipulation, like the aggressiveness of that. I know that Giles with the OMT training, and then the Wichita patient people, they teach you to finesse it, to make it easy and relaxed on the patient, and they're not going to guard. What happens when they guard? They get a muscle spasm. What's like the most common complaint or like adverse reaction to manipulation? It's a muscle spasm. It's a strain. How do you prevent that? You don't beat them up. It's that simple. Like, I don't know why. I just don't get it. Like people, they just love to beat up their patients. Just add a little finesse to it, communicate with them, and it's all hunky-dory from there. I think that's within 5 minutes, or right at 5 minutes, hopefully.
What you said there, a couple of things, eh? You know, you can drop an elbow once in a while. You know, beating up your patient is a completely different thing. You're saying, why do people do it? I think a lot of it's ego.
Yeah,
I think it looks cool.
Probably ego.
I think you scrape the hell out of your patient, or you clip, you know, you got your little clip and you clip it on your patient's neck, and then you do a massive rotary adjustment. You got bang, 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 click, click, click. And some of those videos, I see the patient going, oh, especially with the Y-axis distraction.
The Y strap. Yeah.
This rolls perfectly into your talk, Giles. So
It does.
Can I just apologise, because you guys have really prepared, and you're
done
quoting
nothing.
references and you're quoting journals, and I'm just sort of winging it, really.
well, how many books have you written on spinal manipulation?
I'm the same here, Giles.
You've got
Oh,
experience.
that's all right. I'm glad, Aaron. That's all right. That's fine. I might have written them. It doesn't mean anyone's read them. I've just produced a lot of coffee coasters, and that's pretty much it. My mum's got all my books. No one else has. I wouldn't worry about it. So we'll talk.
That's not true.
Manipulation. Mate. So there's two people have my book. I appreciate that. Thanks, man. You still owe me the money for it, yeah?
It was free.
Yeah, of course it was. Yeah.
No, it was. Hey,
Yeah,
I bought it from like a bookstore or something online. Anyway,
You got what, secondhand? It was probably
No,
one of those charity shops.
it was
charity
like
shops.
it was
yeah?
like $100 or something.
Oh, the refunds in the post, mate. Don't worry. Yeah, all right. Well, we'll talk about spinal manipulation. I think it's a nice segue into it. Clicking joints, cracking necks, cashing checks, $1 million rolls. What else do they say? All sorts of stuff. I like manipulation when it's done well. I hate manipulation when it's done badly. Unfortunately, in 2023, spinal manipulation, or the use of manipulation as a technique, has almost become this egocentric, mono-interventionalist type modality where people on social media, which is one of the most toxic environments I had the misfortune of wading into, are using these techniques for brutality, for misinformation, aggression. I've got to be honest, I hate social media because I hate seeing terrible technique. I hate seeing patients brutalized with what is a very small part of the treatment process. Look, for me, and I've written 3 books on manipulative technique, manipulation is a small part of the treatment process. It is not the treatment process, right? If all you do is crack a joint, give up, because you've lost the whole process. You are using a high velocity, high speed, short distance technique to gap a joint. You're gapping articular surfaces. You are creating, in essence, functional and symptomatic modification for a temporary period of time. How long? How long is a piece of string? 5 minutes, 24 hours? But if all you're doing is clicking stuff and you're not treating the patient off the table and doing what is going to make lasting change, which is the exercise rehab, then all you're doing is a passive intervention. You're basically a very expensive ibuprofen, because it is a short-term fix. It feels good, don't get me wrong. It feels great. You get improvement, pain reduction, you move better, you feel better, but it is a short period of time. The problem I find with manipulation, it's being bastardized. It's being used as a treat-all technique, right? You've got hemorrhoids, click the back. Cognitive dysfunction, click the back. I've got a freaking, Stephen, erectile dysfunction, click the back. Hair loss, click the back. I want a 400 kg squat, click the back. It's become this modality for everything, and ultimately people are seeing this and they're thinking it can cure everything. These poor patients are going into these treatment rooms and they're being smashed from head to foot. Aaron, you said, an osteopathic tenon is the body's connected. Yes and no. If someone's got a foot problem, why are they having their OA smashed to pieces? Why are these therapists cracking people from head to foot? Well, actually, what was it Ed Cohen said? He only ever does an exercise or a set with a specific intention, right? Nothing is done as random. Manipulation should be the same. You're clicking a joint for an outcome, for a rational reason, for a clinical purpose, to get something out of it. Cracking someone for no real clinical reason is basically closing your eyes and just chucking mud at a wall. I'm ranting. I told you I didn't prepare.
Right, it's good stuff.
So for me, it's a great modality. It's a fast modality when used appropriately. It's not a quick fix. It's not going to sort out, it's not changing bone position. We're not putting stuff back in place. I'm not correcting your scoliosis. I'm using this as a way to get my patient into a position that I can exercise and rehab them. Is it appropriate for everyone? No. Is it appropriate to crack every patient that walks in? Absolutely not. Is it effective for some? Yes. Is it not for others? No. Just like any modality you use, it has to be used for the right person, for the right reason, with a specific intention. Why strapping the fuck out of someone is doing nothing but pushing your social media. And when I see people strapping microphones to patients, and one guy with 2 microphones on his wrists, that's not treatment. That's not patient-centered. That's self-centered. That is trying to promote this false narrative of what the technique is, and it's purely ego. And that's a problem, because people are going to start doing more and more dangerous technique to try to get more and more views. And that's where I see treatment going, unfortunately. People are doing crazy stuff to get clicks from random people they've never met. It's like, come on, you don't know these people, and you're creating your own self-validation off a load of strangers. Treatment should be patient-centered, not self-centered. Stop filming your patients. Stop sticking microphones up in places they shouldn't be to try and make sounds louder, and stop falsifying your videos, right? You know, you might as well stick bubble wrap under your table. Sorry. So yeah, I love manipulation. It's a great technique when done well. When it's done well, it's like a dance. It's gentle, it's effective. When it's done badly, it's a brutal technique. But I think, yeah, that's about it, really.
Bang on, 5 minutes.
that was my boom. There you go. That was my unprepared rant for you.
Unprepared.
The microphone thing I can't think of a better way to cheapen the fuck out of the profession of you know, training people. You have to have this crazy loud pop, and if that happens, this is successful. Like,
well, the problem is you're right. If you don't hear the sound, then that means the technique hasn't worked. The patient thinks you're shit, or the therapist just hits it harder to make a sound.
Yeah.
You know, and when you see these therapists just cracking people from head to foot for literally no reason, it's just talk about just smashing the patient's nervous system and hoping something sticks.
Well, it feels good.
I like what you said. It does. Well, yeah, but do you know what?
No,
So
when you get the crack, when you get the crack, it feels good. That's what I mean.
Yeah. But I thought what you said, Matt, was nice. Non-specific therapy equals non-specific results. I like that. Smashing someone from head to foot is non-specific. And I liked like that comment by your mate Ed, basically talking about specificity in exercise. There has to be specificity in treatment. Why am I doing this technique? Why am I doing it? What am I looking to get out of it? What am I trying to achieve? What are the neurophysiological mechanisms I'm trying to elicit? How do those back up my exercise rehab? Because otherwise you're just rubbing shit for the sake of it. You know, there has to be a rationale why you're doing it.
And what would you say, Giles, is the end goal? What's the off-ramp from manual therapy?
For me, the ultimate goal is exercise rehab. I want to use manual therapy, whether I rub it, mobilize it, whack it, click it, crack it. The goal for me is to create I want the patient to move and feel as best as they can to get them into a rehab phase as fast as possible. And ultimately, the techniques I do on the table have to be, the goal is to get the patient off the table and self-reliant, exercising, training, loading, strengthening. Because ultimately, if they want to keep coming back in, I'll take their money. I will, you know, crack their neck, cash their check. I will take their money if they want. But if they're not prepared to do something, you're literally going to be like this, just going around and around. So my goal with manual therapy is you use whatever techniques you can, whether you're going to manipulate it or mobilize it, to get someone into a position where you can rehab it.
Mic drop. Fantastic.
Amen.
Giles, how often do you not manipulate during your, you know, appointments and treatment visits? Depending on, I don't really know what your demographic of patients is, but yeah, that would be interesting to know.
To be fair, I don't tend to use manipulation on the first appointment. I like to use I personally find, until I've gauged how the patient responds to treatment, less is more. I'm a massive fan of less is more. Do the littlest I can to get the most out of it. If I can mobilize it and it works, great. If I can exercise it and it works, great. I can always add in technique, but you can't take technique away. So first couple of appointments, I'm very gentle, low modality, less is more. And then I'll add in, maybe on the second or the third appointment, we might use manipulation, but I'm very anti that new patient coming in and you ratcheting their neck from head to foot. I'm not a fan of it. I think it should be look, great techniques come with good responsibility, and just ratcheting something, I think, also patient's expectation. I'm a big fan of setting that straight away. In session number one, don't come in and expect me to just ring dinger you, because it's never going to happen. If you want that, go find someone else. You know, it has to be an understanding. So yeah. I'm a massive believer, less is more. Sorry, that was a long-winded answer, Luke.
Is that other passive modalities on the first visit, or is it more active-based movement stuff?
For me, I'm a massive believer in both. So I love active and passive technique, but I love mobilization. I think for me, mobilization was my foundation technique. I wrote a book on it that no one read. I love it because I love thoracic mobilization, getting the patients to do this thoracic extension. It's something that I'm a massive believer, getting the thoracics moving. They can do it themselves. It's a really gentle technique, low velocity, low amplitude, minimal risk, and you get maximum results. A little bit more hard work, but you get great benefit. So you don't have to go straight in for the kill. It's a bit like dating. You're not going to go to fifth base straight off, are you? You got to romance them a bit, yeah? Dinner and drinks.
Come on, if you're Stephen, yeah.
I'm Stephen.
Hey, interesting about the thoracic, because obviously that's one thing McGill, out of all them, obviously he's not known for his manual therapy, but one thing I've seen McGill do is the thoracic mobilization.
Yeah,
mate, I've been doing the gymnastics stuff for like 4 years now, and handstands. I'm in my midlife crisis, and the thoracic extension work is something I am doing. Like, mate, I know, get a turkey hair transplant. But the thoracic extension is something that I've been doing on a daily basis. It has literally changed my technique massively. And it's something I get all my patients to do now because it's so easy to do. Fantastic. And they find so much benefit because thoracic extension, shoulder mobility, the two, it's a great thing to do personally.
I'm interested too in osteopathy and chiropractic. Is there a particular class where you're taught how to say yes when you f the manipulation up, you didn't get it, but you're going to say yes as if you really fucking meant it, and you know you didn't get it? Do they actually examine your ability to say yes at the right time?
No,
you fucked it up?
It's perfect.
In our school, it's all about how good you are at using analogies to basically divert the patient's mindset, if that kind of makes sense.
Yeah.
Like that's what I found before. I think when Giles touched on, those traditional chiropractors that are really good explaining philosophy, I found that they fall back on analogies a lot of the time to basically explain to a patient at a simple level of, why they should be receiving treatment. Or what I hear a lot of is, things take time, Like, it's just, yeah.
Bro, you call them out. Sometimes when they say to you, you have to be able to explain it, the elevator pitch. I'd go, okay, give me your not elevator pitch. And then they go, oh, I can't.
The problem is it's a really difficult one because what I'm seeing is social media from all of our professions, all of our backgrounds, every specialist here has an issue because we all look at social media and we're seeing this barrage of the misinformation that having a large social media profile means you are skillful. And people are seeing these people on social media going, well, they've got 500,000 followers. They must know what they're talking about and they must be excellent. So graduates are seeing this going, well, I must ring ding someone's neck on every appointment. I must make someone do this and this because and people are not researching and not reading anymore. And it's really difficult to have a conversation because attention spans are short. People are just taking verbatim what they see on TikTok or what they see on Instagram. And no one reads. It's such a quagmire of snake oil that I really do see, and let's be fair, no one's ever going to post negative results on social media, right? Every single post is an amazing clinical outcome. Every single one. I've never had that in treatment. In 20 years, I've never had these miracle outcomes. You get occasional ones where you go click and they go, oh, wow, that's amazing. And I'm like, well, I don't know how it happened. How did you cure my pain? I don't know. It just was luck. Yeah. But, it takes a lot of work, clinical experience, examination, thought process, reading around it, strategic rehab. The idea that you're going to click away 30 years of back pain just because someone on social media was able to do it doesn't really mean it's actually true. And it's really creating a generation of very misguided therapists and unfortunately very misguided patients.
It's also perpetuated by the schools, the education, the lecturers, especially in chiropractic. And like Luke can, say he understands this because he's been going through it recently. But every lecturer, every mentor, every person that works or takes you through lectures, they all will start pretty much with their miracle story. They lead with it.
For the people who went to chiro school, were you taught mobilizations? Because I was not taught mobilizations in the curriculum. Luckily, the dean became my mentor, so I would meet him at 6 a.m. before school started for a year and a half. Like, he taught me mobilizations, but I was never shown a mobilization in the curriculum.
We were explicitly told, because I asked about it, because I've been a fan of Giles for a long time, and me and Giles eventually got to write a paper together on mobilization versus spinal manipulation, which is in the book coming up, which was so cool.
Nice.
But even back then, I used to watch Giles' stuff, hear him talk about finesse over force, mobilization. I asked my teacher straight out in front of Luke. I asked him in front of the whole class. Remember, Luke? Like 80 people. I said, what about mobilization? He goes, mobilization is the same as motion palpation, and if you any effects you get are going to dissipate after a few minutes. You have to click to get the full effect. And he told the whole class that.
Because the only difference between mobilization and manipulation is speed.
That's what the research says.
That's it. The speed, the technique, positioning, the amplitude is just a slow rhythmical amplitude, slow and gentle. The difference between that and a manipulation is the speed at which you put the impulse in. The technical position is the same.
All the research seems to suggest that, but a lot of chiropractors have a hard time accepting that.
Yeah, when I have students shadow, they're surprised that I don't adjust everybody, and I'll mobilize a lot of people too. They're like, "What is that?" I'm like, "You don't." The fact that you don't know that, and you're in your last try, about to graduate, is a serious problem.
My wife is currently pregnant, and she's like, getting into her third trimester. She's uncomfortable, back sore, ribs are sore. I'm doing a lot of thoracic work with her, and I can be in different minds. I can be like, one day she'll come to me and I'll be like, oh, well, I could just do some mobilization, some rhythmic stuff, really get into it. Maybe I'll get laid if I'm good enough, like Giles, and then, but then other days she goes to me, like, I'm sore at work and you're not there to help me. And I'm like, okay, now I got to think like Locke. What can I give her? What movement can I do to give her so that she can do this throughout the day? That's when I put my Dr. Locke hat on, and I'll prescribe her something to do. And then that is the one she loves. She comes back to me being like, I do enjoy being clicked. I do like the mobilization, but end of the day, I'm at work and I'm not with you for 10 hours a day. And I can do these movements now and I can get through the day.
But I say mobilizations have such a depth to them. I mean, I was brought up on the Maitland system. I mean, we're talking, you got a grade 1 double minus all the way up to a grade 4 double plus, then you're going to grade 5. And you're going to do them at different inclinations. You have to not just PAs, you're doing them at certain degrees. You got to put in your notes. Mobilizations really are so subtle.
They're beautiful. I was going to say just one thing with manipulation and with mobilization. One of the reasons why I'm such a fan of mobilization is no one's ever going to criticize you for being cautious. Yeah. Okay. So if I have a patient that I've never worked with before, I'm a fan of caution. I'm a fan of treating the patient with respect. I'm a fan of less is more. So I'm never going to be criticized. If that patient comes in and I just smash them from head to foot, and there's always an element of risk there. There's always an element that something's going to go wrong. Yeah. And for me, you're always going to be criticized if you're cavalier in your treatment. If you are just egocentric, dick swinging cavalier, something will fuck up at some point. But you apologize for the swearing. There's a kid in the bottom. Sorry. But if you are cautious, you are respectful and you're clinical, then, no one's ever going to criticize you for being safe. But when I see people having these large y-axis long levered manipulations, you think to yourself, it's a bit like your exercise guys. It's like, you're not going to get someone under a bar with 300 kg if they've never squatted before, are you? It's all about progression, layering. It's like making a cake, man. You can always add sugar. You can't take it away. Like I said, social media, as for all its positives, is a significantly toxic environment that I can't see getting any better. And it just seems to be perpetually getting worse. And it's getting worse to the detriment, I think, not just for mental health, but for people's misinformation on when they do see a therapist, they may expect to have these heavy-handed treatments. I feel sorry for new grads. Luke, I'm sorry, mate. It's a tough time to be coming out into clinical practice, because you've got to deal with patient expectations. You've got to deal with the patient. You've got to deal with Dr. Google. You've got to deal with patients that have already diagnosed themselves, that have seen a technique done on social media, and they'll come to you and go, right, I want you to do this to me. It's a very difficult line to transgress. I always ask the patient, or the student, would you let that person do that technique to your wife, your child, your loved one? And if the answer is no, then you shouldn't be doing it to your patient. I would never let anyone ring dinger any one of my loved ones. My mother-in-law, potentially, but not anyone that I am very... but not anyone that I really care about. So I'm not going to do it to my loved ones. I'm not going to do it to my patients.
Okay. Fantastic.
Sorry.
Obviously, that spun off into some conversations, which was great. Now, anyway, okay, let's move on. So, Big Daddy Dr. Dre is up next, talking about orthopedic tests. I'm looking forward to hearing your thought process on this. Dre, go ahead. The floor is yours.
One thing that I think Luke will kind of understand a little bit more, since he's still in the thick of things, that what we get taught as manual therapists, as doctors, providers, whatever you kind of call it, that works with the musculoskeletal system, is that orthopedic tests, specifically orthopedic tests, have a ability to diagnose patients. So I specifically remember going through clinic, so I asked them, what's your diagnosis? I'll say whatever, shoulder impingement, rotator cuff strain, multi-directional instability, blah, 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 blah. They're like, oh, well, what orthopedic test did you do to confirm that? I'm like, what do you mean confirm it? I don't have an MRI, I don't have an x-ray, I don't have all these other imaging that can quote unquote confirm what's on the inside. I have this one test and it activates 9 different muscles and puts stress on 4 different connective tissues. Why would I use that to, diagnose one potential thing that's, I'm not going to send out for surgery, so it's pointless to begin with, right? So I think what we kind of get caught up with too is a lot of these tests, about 90% of them, I would say, are not diagnostic in the way that we kind of think it is. It's diagnostic in the true definition of what a diagnostic test is. So it's a characteristic of a certain subset of pathology. What tissues are being affected when you put it underneath this particular load? Once we can kind of grasp it in that framework, we can actually apply it to, okay, let's reverse engineer this, and what am I actually going to put this patient under so I can get them more comfortable with this load? If anything, it's literally just a test to see what pisses them off. I can do 1,000 of them, and at the end of it, everything hurts. So it can't be that much of a diagnosis tool. Like the clinical side of it, I think is something that we kind of, I definitely see it a lot where I'm at in Georgia, but I see it all the time where people will write it down, positive O'Brien, positive drop arm, positive this, positive that. And I'm like, I really don't care. Like, let's try to figure out why that's positive. You're 95 years old. Maybe that's part of it, right? So if we're going to try to, put people into a certain subgroup, we really have to do it in a better way. And I think orthopedic tests, majority of them are just riddled with inconsistency. They're riddled with poor theories that we can't really test. Kind of the same thing with, you're 85 years old, you get a shoulder MRI, you're going to have a torn rotator cuff. It doesn't matter if the whatever orthopedic test is positive or negative. Does it hurt when you do this? Yes. Okay, let's try to get you to be able to do that. And that's honestly the goal. There's too many students that put too much weight in if they're a good clinician or not, if the orthopedic test is still positive, or if it becomes positive all of a sudden when they're in the course of treatment, not realizing that they almost have to cause, almost have to cause a certain level of regression in motor pattern to be able to kind of undo bad habits. We have a new doc that just got hired with us, and she was really confused on why I would do orthopedic tests, but not the way that we taught them in school. And when I tried to explain to her, like empty can stresses 9 different tissues. Pick one. Which one's pissed off? And she couldn't even name, most of the tissues. So it's like, why am I going to keep doing that for patients? I see 40 patients a day. I'm not doing O'Brien and empty can 40 times a day. I will lose my mind. And it's little stuff like that where it gets me really annoyed, because not a single time in my life, personally being injured or as a clinician, have I ever put positive empty can on an MRI request and had it denied or, accepted because that was on there. It was pain, not responsive to care. Pain. That's good enough. So if that's good enough for insurance company and people that, can take away my license, that's good enough for me as far as the bare minimum. Obviously my standards, my intent are different, but as far as a base standard, we really have to stop putting so much leeway in orthopedic tests. They're kind of shit. Neurological ones we can get into a little bit later, but orthopedic tests for the most part are shit. So
that's absolutely so beautiful. It's so absolutely perfect. One of the greatest clinicians I know has all the ability to test every structure in the shoulder that you can imagine. Her diagnostic skills probably almost better than an MRI. But how does that translate to the problem? Can't rehab it, but can test everything under the sun, under every different condition. Well, yeah, that's fucking useless.
When I had some clinics in central London, we had a lot of new grad associates, and we would find that they would do a myriad of testing because they just didn't have the confidence to properly diagnose. So they basically would just test just to fill the time because they were unconfident in actually doing proper diagnosis or coming up with a proper treatment program. A lot of it was down to sort of lack of knowledge or lack of training, to be fair. They just relied on a test, hoping that they might get lucky, if that makes sense.
Perhaps as an undergraduate, really all we're learning is handling skills. And that's really what we're doing, is doing a lot of handling skills, thinking in a theoretical manner, but really that's the end of it.
Yeah, it's cover your ass. That's all it is. Because, like, you know, going back to the whole, did we learn how to mobilize? It's like, technically we did, but we learned it within a technique of a technique, right? You know, pumping the disc in Gonstead for a high L5, that's mobilization. You have Cox flexion distraction, that's mobilization. So we learn these things, we just don't learn it in the context in which we can use it in other ways, right? So it's when it comes down to when you're fresh out, your only job is not to kill people and then learn everything of how to take care of people over the next 5 years. So it's like, if I'm in Georgia, so it's very philosophical here. And if I kind of put, quote unquote, in my bio on my website, Gonstead, diversified full spine, and the myriad of other things that kind of looks like what I do, and someone were to, let's say, fracture a rib, or someone were to have a fractured rib that I adjusted, and I put Gonstead on there, what I'm being held accountable for is the technique of Gonstead. I'm supposed to have an x-ray before I adjust somebody, right? So I'm supposed to have this orthopedic test before I send up for an MRI. It's not even the same thing. They don't even care about that. But they definitely care that if I have 3 so-and-so qualified qualifications in these techniques and I don't have that x-ray, I'm now being held accountable because it's what the like-minded clinician would do down the road. If that's a Gonstead or a full spine guy that takes x-rays, I'm now being screwed on. Not my competency, not the fact this person had metastatic cancer, but it's literally based off of a CYA. And that's what orthopedic tests are. Outside of focal neurological deficits, that's what neurological tests are. That's what freaking strength muscle testing is. It's all by itself completely shitless. Now, if you have the ability to, you know, kind of go all cliche murder mystery corkboard and have all the pins and all the red yarn connecting everything, if you can put it into that little Charlotte's web of a concoction of thought, then by all means, test the crap out of it. But if you don't know why you're doing it, then just stop doing it. You're literally saving time. You can see more patients. You can actually learn more about what the hell the body's doing instead of just testing a stroller for 2 hours and coming up with it hurts.
Yeah,
like, that's all.
I think your case history is going to be more important than any clinical test. I think there was a research study. Yeah, I think that 80% of your diagnosis is done through clinical case history, and only 5 to 10% through testing. I can't remember where it was written, but for me, the most important part is the verbal discussion with the patient. I think you're going to get more information through that than you are through randomly not having a specific idea, just getting them to move around without any real thought process. You have a really good case history discussion, and then you can tailor what you think is appropriate after that.
It's that communication and education, right? There's 2 things that it comes up nearly every podcast. Something that really represents a big part of what we believe on this podcast is those 2 things. So often we will just get things around the wrong way. You know, we'll major in the minors. And talking about orthopedics, you know, we were given a PDF of 160 orthopedics and told to learn them all in isolation. And this was before we had adequate biomechanical, physiological, even anatomical knowledge. And we really learned them in such an isolated manner that by the time it came to use them on patients in the center, hey, Luke, it's like, we're like, oh, like okay, like O'Brien's, or like, okay, I'm going to do a straight leg and then I'm going to do a pectoroo, or like you're really just saying a bunch of old men's last names, and really what the information you're getting is very little. And from here, I'm going to throw to Mo, because I'm really excited to hear his talk. He's talking about integration over isolation, or integration not isolation, and I have a feeling that what you just spoke about, Dr. Dre, is going to 100% come up in what he's going to talk about as well. So the floor is yours, Mo.
So I've been a manual therapist since 1995. I'm a manual therapist that doesn't currently use manual therapy, because I don't think manual therapy, hands-on, doesn't fix injuries. I'm a clinician, a diagnostician that doesn't use orthopedic special tests, because they don't assess for what we're led to believe they assess for. What I'm going to talk about today is the way that I practice, that's based on, I suppose, years of experience, having been in the place that Luke is now, probably getting to the place where Dr. Locke is. My job, essentially, is progression and regression of exercises. Again, I think social media, as Giles said earlier, has been a big influencer in terms of the communications that I have online with prospective clients. And one of the most common questions I get asked is, have you got an exercise for said injury, rotator cuff strain, impingement syndrome, back pain, you name it? My response is always the same thing. There isn't one exercise that's going to fix that problem. It's going to be an integration of looking at your training program, looking at your lifestyle, looking at all those other factors that we've all talked about: sleep, hydration, diet, stress. It's those things that's going to fix your problem, not that one or two exercises that you are purported to, fix your rotator cuff strain. I think isolation has its place. And I think isolation has its place in the early stages of injury. I think if we take a lower limb injury, as soon as that client is walking, is weight bearing, then I think those isolation exercises become redundant, because you're already loading the lower limb with more force than you can produce of those isolation exercises and those therabands that are so commonly seen on Instagram. Once we're past that stage, what we should be trying to do is integrate rather than isolate, integrate into functional movements. So if we look at human movements as it's in its component parts, we've got our squat pattern, we've got our hinge patterns, we've got our push patterns, we've got our pull patterns, we have our rotations, and we have our gait. And essentially, if we can break those 6 component things down into their fundamental parts and regress and progress those exercises, we can take a client from the acute stage of injury all the way back to full functional fitness without touching them with our hands. The end.
I love it. Any thoughts?
So beautiful.
Very well said.
Poetic.
Art.
And total blasphemy for 90 to 95% of our professions.
Unfortunately, I think 90% of our professions don't know how to exercise. It never surprises me when I teach, and I've been lucky enough, like most of you, to teach across the world. I think I've been to about physically 45 countries now, and every time I go to a country, I'll sit in front of a class of. I've always trained. I'm not to your guys' level, but I've always trained. And the people that are in their 20s and 30s that have never stepped foot in a gym, yet these are healthcare professionals. I'm not asking them to, have a 6-pack and have a crazy squat, but they at least have an understanding of how to prescribe exercise and how to train. But the vast majority that I work with and students I see don't even do that. And it's shocking. Nutritional ignorance. The people. It's just it never surprises me how people are unfit, unhealthy, and these are healthcare professionals. And I'm just like, wow, guys, you need to look after yourselves, because if you're meant to be looking after your patients, you need to know at least the basics of how to eat well, at least how to train, basic stuff, push, pull, squat, hinge, get the understandings of the basics. Never surprises me. Most don't.
And sure, that's what drove us all into the profession in the first place. It was our love of exercise and our love of training and our love of understanding how to make the human body function better. I think
how much exercise did you learn at osteopathy school?
Nothing. I learned nothing at osteopathy school. I taught physiotherapy for 15 years, and all I taught them was basic banded exercises, early stage rehab.
It's a real shame.
It's terrible. You know, I say this with the greatest of respect to all the professions. You know, we aren't doing a very good job of preparing the new generation to come out into industry, being able to be effective clinicians and practitioners, because the education system is, dare I say, it's so woefully inadequate in terms of exercise prescription. I had a conversation with a fellow lecturer. She was second marking a dissertation. I was first marking, and it was about blood flow restriction training, BFR. And she said, "Oh, I've never heard of that." Bear in mind, this lady's been a clinician for 30 years. Never heard of blood flow restriction training. Never read any of the research. Never.
I've got a free course on it. You can access it. It's fine.
Yeah. You know, and I think
Exactly.
that's the problem. You know, it's, again, like Matthew was saying with the opioids, people are being led to believe that what fixes their injuries is banded rotations for the shoulders and TheraBand to, you know, fix the lower back injury. And actually what it is getting them back to moving properly, teaching them to move properly if that's needed.
I think a really brilliant idea would be if all the professions, upon the first day the student enters university, that they are told that by the time they graduate, and they can only graduate, if they can deadlift double their body weight, squat double their body weight, be able to assess a walking pattern and take a person to a jog. Might take you 5 or 6 years, but that's the process. You can't graduate unless you can do those things.
Yeah.
It's just walking the talk at the end of the day, right? Like I had a patient come in the other day, and he sort of said to me, he's like, "Oh, I've just come from the doctor, you know, he's told me to rest. That's how I'll get better." He's like, "Oh, you look like you work out and exercise yourself." I was like, you know, yeah, I'm spending time out of these sessions working on myself so I can help people like you, like putting myself under certain exercises so then I can apply it to patients like yourself. And already he said to me, he's like, "I'm in a better mindset being told that I don't have to, you know, lay in bed for 8 hours a day." And me and Brogan were chatting about it the other day. It's funny. It's like, it's socially acceptable to spend 2 hours in front of a TV, but then my friends will give me grief for spending 2 hours in the gym a day. You know,
Absolutely.
It's so funny when that kind of stuff happens.
Well, it's stuff like that that's the exact reason why schools are doing just fine preparing clinicians for what the general public will expect of them, right? It's because they don't. There's a spectrum between ignorance and stupidity, and oftentimes we, unfortunately, and for, you know, out of respect, we push people towards the ignorant side as if like, oh, they just don't know any better. We do that to clinicians, we do that to specialists, we do that to even our patients, we do that to the teachers in whatever level of school. But they've been told before, like almost guaranteed, they've been told, hey, this is probably something you should be doing. And now they've been given the information, they've been given a way to kind of, I'm not going to say research and have that butchered all over again, but to find out where their line in the sand is. And they are making the cognitive and conscious decision not to take it on. So then now they're going to the stupidity side, right? Because they're willfully being ignorant. And if that's what the schools know our patients are, because we put absolutely no responsibility on them when we have some of these talks, it's always about the providers, that they're doing just fine. They're going to get rid of the status quo, right? If you go to this person, most likely they're not going to kill you. Natural symptoms will resolve your issue. And congratulations, they went to our school, Harvard of whatever profession you're in. And it's only people like us who have a higher expectation for our professions than most people do that find an issue with it. And too many people are accepted with mediocrity. And I hear so much, it's, you know, it's the generational thing. There's been bullshit throughout centuries. All right. Like mediocrity is a human trait because it's your homeostatic, like natural level of what to expect of yourself. So it's like, that's not a bad thing, but also we have to expect more. Otherwise we're just going to stay stagnant. And, you know, my 500-pound life is just a senior yearbook picture at that point. And it's getting to that. And, you know, not to hate on people or fat shame them, but it's not, it shouldn't be that accepted as it is from providers, but also as patients. And if you can't, you know, get a hold of your own demons, how can you expect patients to listen to you on yourself? So it's not even a appearance of self-esteem thing. It's literally why would I listen to you? You're supposed to help me, but you look just like me. It's redundant.
Fantastic. Absolutely loved it. You smashed it, Mo. Really, really good. And the follow-up discussion was great. We have one more. We have the legend himself, the Doc Locke. He's sat there very patiently. He's got a whole bloody generations of knowledge, and he sat there listening to us squirm and talk out of our ass. Speak for myself. But yeah, we would love to hear your thoughts. Close it up and give us some knowledge, man. Is technique important, or can you just bust that myth that's been going around lately that, you know, you can pick up a deadlift however you want?
Well, let's face it, you're also delightful to listen to, and I've got so many things have inspired me by just hearing the words that you've said, and I'm going, oh, God damn, that's good. I've got to use that somewhere. So I appreciate everyone's input there. Realistically, of course, let's face it, is we're not going to change people who think the technique doesn't matter. I was actually at the National Space and Rocket Museum in Alabama recently, and they have all these scientists there. They actually have serious rocket scientists walking around the place. And these are people who've worked on the Apollo programs. They've worked on everything, and they're retired guys, and they're all... So I said to one of them, what do you do when you run into somebody who believes that there's a flat Earth? And they just said, we don't talk to them. There's no point. And I really got it, you know. You just don't waste your time with... If someone wants to say such dumb shit that technique doesn't matter, there's no discussion there, because they are just terminally stupid people. And you're going to waste your time trying to talk to somebody who's stupid. So they've been graduated to read research papers that they don't understand. That research papers that are written by people who don't understand the topic in the first place, that are peer-reviewed by people who don't understand the topic, and published in journals that don't give a flying fuck anyway, as we can see. And you're going to then give that to a student, and the student who has no clue about the intricacies and the nuances of assessment is going to quote that because it's the latest study. Well, you know what? Let's face it. Don't quote a study unless you're a clinician. And that's an important part. You got to be a clinician, because then you can framework it properly. Let's look at Peter O'Sullivan. Seriously. I want to know a single world-class athlete that this guy has ever brought back through his work. And I'm just talking crickets out there. Now, don't speak on a topic that you don't have any understanding of. If you haven't rehabbed a top lifter, don't write a paper on lifting technique. Just get game over. You do rehab somebody who's got a top-level demand, you've got the right to talk about that. But if you're just sitting there in an academic chair and you seriously haven't got results of bringing people back, you haven't got a score on the board with high-level lifting technique, then seriously, don't write about it. When it comes down to it, it's fairly straightforward. Technique is related to load, but technique is motor skill too. If we look at the absolutes in life, and that's really where it comes down to, we can look at parkour athletes, and we can look at the biggest squats in the history of humankind. Every single one of those pursuits demonstrates excellence in sagittal control. There's no deviation. If there is deviation, the lift fails, the person gets injured. So we can look at the lighter lifters who may have technical flaws, someone who squats 200 kilos but weighs 50 kilos. Well, that's nothing like a person who squats 500 kilos.
Exactly right. Yep.
There's the absolutes. It might be good for you, but it's not the absolute limits. And the absolute limits always display perfection, because as soon as you increase that load to those levels, you've got less than a 64th of an inch to play with that weight related to your base of support. Now, you look at, let's say, the parkour athletes. You can look at an NBA player who lands with a significant knee valgus occurring. Yeah, but dude, that's a guy's body weight, and he's going to be landing maybe a meter. Watch a parkour athlete jump 10 meters. They're not going to display a millimeter of deviance into valgus, because you need to shock absorb through the plane. And the load is absolute. So when it really comes down to it, anyone who says the technique doesn't matter how you do something clearly isn't very good at anything themselves. There's no great musician who doesn't have outstanding technique and they practice all the time. Golf practitioners, tennis professionals, they practice twice a day, 2 hours a day, and they don't practice shit technique. They are working on excellence of performance. And the same thing we do in any form of lifting technique. And because we're hunter-gatherers, we have a hunter-gatherer movement pattern that's very efficient for low load. Bend forward, use the passive elements of your spine to pick something up. Doesn't cost much as far as calories go. But when you start loading a couple of 100 kilograms up into certain patterns, you better use your active musculature to protect the passive structures. It's so simple science. It's evolutionary, functional evolutionary anatomy. We are constructed in the way we are because it's taken us 4.4 million years to get to this body. So for people to say things are so freaking nonsensical that technique doesn't matter, we just have to remember the famous saying, you don't wrestle with a pig, because you're both going to get dirty and only the pig's going to enjoy it. It's game over.
There's so much to unpack there. And I think sometimes some people will say, okay, well, you're drawing extremes. You know, sometimes people will say, oh, Dr. Locke, you're drawing extremes. You're talking about the extremes. But it's also important to understand mechanisms of injury, right? We're talking about load, but then we're also talking about traumatic load that can happen in one bout of activity. But then you listen to Dr. David Johnson talking about movement proficiency over, or movement dysfunction over a long time, right? The intensity is low, but the movement pattern's incorrect over a long period of time, degradation of passive tissue structures. And that's why movement proficiency is not just important when we're having high force loads running through the system. It's important in the daily things as well. If you're doing a bunch of orthopedic tests and you're not asking your patient, what are the provocative movements? You know, does it hurt when you get out of the car? Okay, I've got a hot disc, whatever. Yeah, you haven't asked your patient what they're doing on a day-to-day basis that may be picking the scab, to say it as McGill will. You're going to give them stuff to improve, and they're going to be continuously doing provocative movements, and you haven't got off your ass and asked the question that you should be asking. I just wanted to touch on that. And then another thing, just to touch on what you said about Peter O'Sullivan. When I was listening to you talking to Tate, and he said, you know, what are these people saying? And you go, oh, they're saying you can lift however you want. I was thinking to myself, quote Peter O'Sullivan, he literally says, lift with a loose belly, loose back, lift, don't worry about it, lift with a relaxed spine. These are his words. Like, you can go on YouTube and listen to it. This is not necessarily in the literature, but if you go listen to him speak on YouTube, he will say these things. And I'm just like, I bet you if you said that, Tate would have been even more taken back. Like, whoa, really? And this is not just some random person. He's a random person in our industry, strength industry. But
he's not a person in the strength industry.
No, he's not.
He's an academic.
And people are following him in academia and they're being led astray. And I think that's something that concerns me,
The issue lies in the fact that many of these practitioners aren't conditioned enough themselves to be able to pick up a weight that's heavy enough to cause that one traumatic episode. Yes, 10 years down the line, their poor technique may well result in a disc prolapse or herniation. But, I think that the current paradigm where that sort of philosophy where technique doesn't matter, I think is perpetuated because their lifting proficiency, their movement efficiency or proficiency is so low that it doesn't matter.
Everything's related to load, isn't it? And here's a legit and bullshit question for everybody. Are pig spines acceptable for understanding the mechanism of disc injury?
I'm going to say yes. Because based on the lordosis, based on the similarity, based on the tissue, I've researched it. I think that porcine studies or pig spines have a place in the research. Is it the be all end all? No. Is it a part of the pie? Yes.
I'm going to say no, because they're quadrupedal, not bipedal, primarily. And there's different loads placed through the spine in different regions.
Well, fortunately, the muscles that are in the neck actually contract axially. That's why they're used to it.
But a lot of that is not known, and a lot of that is really deep in some of McGill's stuff. So it's really easy to look at McGill's work and say, "Oh, this is done on dead pig spines." Again, is it a be all end all? No, but is there utility to it? I would say there is. Yeah.
I love this stuff, baby. I eat pig spines for soup. They're the best things. You should actually do it. You can go to your Chinese butcher and you can get the pig spine. They're cut down sagittally, and you can see the nucleus and you can see the annulus. It's freaking awesome. You cook it up, and it tastes good. You can eat your multifidus as well.
You got me to do this as well, which was really cool. I mean, the first thing you say in your seminar is you should be able to draw, or mold a vertebra off the top of your head and that label everything, label all the structures, adjacent structures, all the other ones that move around it, close to it, towards it. And even just a simple task of that, how many people can do that?
That should be a hurdle requirement upon leaving university. Sit you in a room, no books, here's your piece of clay, go.
Exactly right.
So, separate question outside of what Locke just spoke about, sort of. Me and Brogan were talking about that assessment that you did on Dave Tate, the video that came up. Brogan was sort of filling me a little bit on, I'm not up to date in the full powerlifting world. But what was his previous history in terms of, like, I was shocked with the shoulder mobility that he had. I thought it was a joke at first, and then he couldn't even touch his buttock from behind.
No. Well, Dave has had 2 hip replacements, okay?
Yeah.
Now, he doesn't want a shoulder replacement. So 20 years ago, he was in a fair bit of pain in his last meet, getting under a squat bar to just get his arm under there. And he just decided he didn't want to have a shoulder replacement. So his life has been focused upon, screw that, I don't want to get a shoulder replacement. So he's basically been very, very, very protective of allowing it to be loaded. He likes to bench still, and he can bench okay, but that's a 20-year dysfunction under there. And what's his goal? His extreme goal, Dave's goal, is very clear. I don't want to have a shoulder replacement, and I don't want to lose any more than I've got right now. So my simple thing is let's just get you a little bit more then. I don't have to put you on a squat bar. What's the patient's goal? Not have a shoulder replacement and to not lose what he's currently got. And he made that super clear. That's all he's after. So all I've got to do, get him a few more degrees of freedom, and I have serviced the patient.
Yes, just the build up of just poor biomechanical movements over time, right?
Oh, I think there's so many things that are related to the bone spurs he's got. He's got some significant arthritic issues under there. There's so much that it was not there for me to perhaps go through that assessment as much as saying, so what do you need me to do? Okay, I'm going to give you this to do that. And then I'll catch up with him when I get back to Ohio. I'll probably chat to him in a week or so. And then we'll take it to the next level, a little bit more. That's all it's going to be. I just want to improve his function so that he's got more capacity that will keep him away from the shoulder replacement forever.
Oh, yeah.
And I find it real interesting. You always talk about you ask every class, or you said on the podcast, like, what's the muscle that maintains the lordosis most efficiently? And obviously, a lot of the time, majority of the time, people were either confused by the question or they don't really understand what the answer is. You went through it a little bit on the podcast, which was cool for probably the first time maybe on a podcast. It was cool to hear you go into it a little more detail, iliocostalis and longissimus and erectors and their role, especially based on their leverage in the thoracic spine down into the lumbar spine. Can you touch on that a little bit? I feel like that's a valuable little lesson for our listeners.
Well, actually, Dr. Dre will love this because lats play a big role in this one as well. It is so, which tendon is the furthest from the axis of rotation of the spine? Well, it's your thoracic components of your erectors. So the tendon of the iliocostalis and longissimus is furthest from the bow shape of the spine. Therefore, its ability is to produce that lovely compression and lordosis control. And then you go to the next level down and you got your lumbar components. They're also giving you your posterior shear control plus compression. So the differentiation there is they're closer to the axis of the spine. And then you're going to get your multifidus, which is segment by segment by segment. That's not going to give you lumbar lordosis control as a whole. And what is it that keeps the tendon down of the iliocostalis and longissimus? Welcome to your lats. There's your retinaculum of your lumbar spine. So the lat relationship to your control of your lordosis can be quite strong. And then we can go a little bit deeper and say, what's the fourth layer there? And you're going to get to your proprioceptive musculature. your intertransversari, and your interspinali. There's realistically the 4 layers of lumbar musculature. We often only think of the 3. It's because they don't produce force production that they got ignored. So there's the beauty of the lat sitting over the top as a retinaculum, and right down the bottom there, you've got your basically highly muscle spindle dense musculature. And in between it, you've got 3 layers of muscles that have different functions. It's actually pretty easy, isn't it?
I love the way you explain it. That's why I just wanted to ask you to do that, because in various educational situations, whether it's physio, osteo, chiro, they will teach different muscles and kind of in terms of their importance in isolation. For a chiropractic experience, we learned a lot about multifidi in terms of palpating it, feeling it, intersegmental control. But we didn't learn much about intertransversari rotators or anything of that, the ones that are closest to the muscle, acting almost like transducers, providing this proprioceptive information and then almost outsourcing that work to the multifidi. That kind of concept was something I learned from you, because everything we learned about the multifidi was quite isolated, I found. So that's cool. Thank you for explaining that. I'm sure people that are listening, that's helpful. If you want to know more about Dr. Locke's philosophies or his ideologies or how he teaches or his beliefs, he has a course coming out in 8 weeks. I know a lot of people, 6 weeks, I have a lot of people that message me. They ask me questions about stuff you say all the time, because a lot of like you said on the podcast when you spoke about your course coming up, you said something along the lines of, this is my entire career of knowledge, so it's hard for me to really break it down on podcasts and explain it all. But for those that are listening, your opportunity is coming. This will be one of the leading educational platforms in the world, so I'm excited to go through it myself, and I'm excited for other people to do it. So
absolutely, 6 to 8 weeks, the Lumbar Spine Leadership Academy. Let's call it what it is. You're going to have to apply to get in. Not anyone's just going to get in, because there's a level of expectation that as a personal trainer, as a physical therapist, as an osteopath, as a chiropractor, there's a certain level of expectation that I would appreciate, because other people are going to want to be in the course. So it's going to be capped through a North American group, capped through a Southern Hemisphere, and maybe even a European one. And the plan is it goes on. We start it, and every month there's more education.
I like that. I think it's going to be amazing. And then also for those that are interested in learning more with Dr. Marv, he has a lower body lifting seminar coming up, Snap Fitness, Seabrook, August 24th, 7 to 9 p.m. Is that correct, Dr. Marv?
Yep.
So that's for local people? And people that...
And then I'm gonna record the whole thing and put that together online. So
cool. And then you've also got other projects that are coming. Can you talk about any of them yet?
Hopefully big announcements next month, and another announcement the month after. So brilliant. I've been working a lot of hours, not just on practice, but on some education stuff.
I'm definitely looking forward to that, and once that comes out, let me know. We can share it across our platforms. Then we obviously have OMT training, which is Giles and Jimmy, and that's a fantastic platform. And it feels like every week there's a new course on there. If you're a clinician, if you're a therapist, if you're any of these people, go on and take the opportunity to learn off these guys. A lot of their courses are free, and then you can pay at the end if you want to get a certificate, so that it can go on your CV or whatever, or hang it on your wall. They do some fantastic stuff around assessment. They do some red flag stuff. I mean, it is fantastic, not to mention blood flow restriction, IASTM, deep tissue work, osteopathic articulation, mobilization. They have 3 books. They have a book coming that has yours truly involved. Stephen is involved. Luke's involved. Even Matt is actually involved with the X-ray paper as well, which is fantastic. So that's going to be good. So keep an eye out for that, and jump over to that platform if you guys want to learn any more. Anything I missed on that, Giles?
No, mate. It's that'll be our 6th book, actually. So yeah, that'll be a good one. It'll be a good one.
Luke, you're going to be graduating in 9 weeks, so congratulations and good luck with all of that. Round of applause. And then Matthew, anything from you, Matthew?
No, thinking about doing a PhD in biomechanics, but that's it.
Do it, bro. Definitely do it. Cool. Okay. Apart from that, does anyone have any closing thoughts?
Thank you for your wonderful day today. It was a great start to the morning, great man. Most appreciated.
Good night.
Yeah. I mean, you guys need. It's like 1 a.m.
Yeah, it's 1 o'clock in the morning now.
12:52. Yeah.
Hey, thank you guys so much. Seriously, we really appreciate it. I have a couple of quotes here from some standout quotes from this podcast, and then I'm going to close and we're going to go. Falling in Style, Dr. Dre. I liked it. It was really good. I see 40 patients a day. I'm not doing O'Brien's 40 times a day. Matt, convince them to believe it. I thought that was a profound thing you said, especially when it comes to this. Luke, when we had a discussion around functional movement diagnosis, and then Locke with your classic line, put the MRI in the corner. I love that. And then Mo, my job is progression and regression of exercise. To the point, beautifully put. I think that was fantastic. We'll finish off with Redmon. You can drop an elbow once in a while. Okay. And many, many other great quotes and fantastic content. Thank you all so much. It's been a long haul, but I have loved it. As Locke said, I've been inspired. You know, there's like new questions in my head. There's more research I want to go look at, things I want to double down on and think about. Would love to have all of you back on at some point. We're definitely going to be having more podcasts and having more fun. But thank you for the 1000th time, and have a fantastic night, morning, or afternoon. Lots of love, lots of gratitude. God bless. Peace. Thanks you guys.
All right, guys. Take it easy.
Yeah, everybody.
See you, lads.
Yeah.